Start, Pramod.
Meeting is not recording, it's not started. Recording not started. Yes.
Yeah, it has started.
Good evening. Good evening, everybody. Welcome to Maharashtra Orthopaedic Association MOA Foundation Day and Week celebration. Today is 5th day. I welcome our President, Dr. Wasudeo Gadegone, sir, MOA President. I also welcome our esteemed speakers, Dr. Vijay Kakatkar, sir, Dr. Shrikant Tamhane, sir. Today, I am immensely happy to welcome Dr. Vijay Kakatkar, sir, as he is my teacher, mentor, and guide. His blessings and motivation has helped me in my career. I welcome Dr. Vijay Kakatkar, sir, who will be speaking on osteoporosis, back pain, how to prevent and treat. Our next speaker is Dr. Shrikant Tamhane, sir. He is an endocrinologist from USA, and he will going to speak on osteoporosis overview. Today, we have with us Dr. Sandeep Birasis, esteemed EC member as a moderator, or Dr. Arjun Viegas as a coordinator of this event. I welcome Dr. Kiran Savji, sir, and all other EC members. I request our president to give his welcome address.
I am Dr. Wasudeo Gadegone, President of Maharashtra Orthopaedic Association. Welcome all members of Maharashtra Orthopaedic Association and viewers of the OrthoTV for a very prestigious webinar in continuation for the details of osteoporosis. We are here with us a renowned orthopedic surgeons Nasik and a very senior member of Maharashtra Orthopaedic Association and past president, Dr. Vijay Kakatkar. He is going to speak on what are the problems they are faced in osteoporosis by after getting in back pain and so many other problems. And another a very brilliant man who is working as an endocrinologist in America, Dr. Shrikant Tamhane, is going to get us all knowledge about how the osteoporosis progresses inside the body and how it can be prevented and can be treated and how it can be diagnosed as early as possible. So over to you, Dr. Sandeep Birasis, to introduce Dr. Vijay Kakatkar.
Good evening, all MOA President Dr. Wasudeo Gadegone, Vice President Dr. Pramod, Shinde, and all the respected faculty and all the viewers. So on this webinar on this about the MOA Foundation Day, about the love, fitness, and prevention orthopedic diseases, the first speaker is Dr. Vijay Kakatkar, sir. Kakatkar, sir, is one of the senior most orthopedic surgeons who started his practice in Nasik in the year 1977. And I am proud to say that he was a past president of the Maharashtra Orthopaedic Association, and he has been involved in active teaching since over 45 years. He has having his own hospital in Nasik, which is a accredited PG institute. Sir has been faculty in various national as well as international conferences. He is a faculty for the AO trauma, and he has got enormous publications in various journals, including JBGS. So, sir will be giving his talk on osteoporosis and back pain, how to prevent and treat. Over to you, sir. Thank you very much for joining us.
Thank you. Thank you, Dr. Gadegone, Pramod, Sandeep, Kiran Savji, Arjun, and OrthoTV. I think it's my great pleasure and honor to participate into this prestigious webinar on one of the burning topics of today, that is osteoporosis. I'm going to mainly talk about the osteoporosis and the back pain, which is the topic given to me today. Can you see my screen?
Yes, sir.
Yes, sir.
So, as one of the founder members of the Maharashtra Orthopaedic Association, it's my great pleasure to see the Maharashtra Orthopaedic Association growing in academics in leaps and bounds in the last couple of years. And I am extremely happy to see Dr. Gadegone as one of the academic person sitting in the chair of a president of the Maharashtra Orthopaedic Association today. I'll start my talk about the osteoporosis and back pain, and I'll try to finish it off in about 40 minutes, which is the time given to me. By definition, osteoporosis is a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration of bone tissue with a consequent increase in bone fragility. So, with all these complicated words, ultimately it boils down to getting fragile bone, silent killer. WHO has given some criteria for defining a particular patient as being osteoporotic. The bone mineral density with a 2.5 standard deviation or more below the young adult mean value, that is a T-score of less than minus 2.5, is labeled as osteoporosis. If the score is between 1 to 2.5 below standard deviation, then it is called as osteopenia. And if it is above minus 3.5, then it is called as severe osteoporosis, and it is usually associated with pathological fractures. If we see the prevalence of osteoporosis, approximately 200 million people worldwide are involved in this particular problem. And with the increasing longevity, with the advances in medical science, the number is likely to increase every year. About 54% of the postmenopausal women have osteopenia and 30% have osteoporosis. So you can understand the severity of the problem. That is almost more than 80% of the females after the menopausal period, they have some kind of a problem of bone, either in the form of osteopenia or osteoporosis. This is basically classified into two main groups, primary and secondary osteoporosis. Primary osteoporosis represents the bone mass loss that is not associated with any other illness, but it is primarily related to the aging process and loss of gonadal function in women and aging process or male andropause, as it is called as. And secondary osteoporosis is actually a result from chronic conditions that contribute to bone mineral loss or from effects of medications or nutritional deficiencies. So it is not related to basically the hormonal conditions, but it has got secondary factors involved in it. And if we see the list of factors which are responsible for secondary osteoporosis, there is a huge list like alcoholism, then calcium deficiency in the diet, various GI problems like malabsorption, gastric and bowel resections, then various deficiency problems like vitamin D deficiency, then number of endocrinal problems like hyper or hypoparathyroidism, and then hyperthyroidism, hypophosphatasia, and problems related to the liver, kidney, and osteogenesis imperfecta, multiple myeloma, and so on. So there are so many conditions which can lead to secondary osteoporosis. Bone is a very dynamic tissue. As we all know, there is a continuous new bone formation and absorption of the old bone going on in the body. And with the age, the osteoblastic or the bone formation activity becomes more and more slow and sluggish, and the resorption process becomes more and more prominent. And that is how you'll end up with osteoporosis. There's a beautiful presentation in a graphical form how one develops the density in the bone. You know, from your birth till the age of 25, one attains a peak bone mass. You know, your bones become more and more stronger and dense because of the body demands and the activities that you are going to do. After the age of 25 till the age of 40, 45, there is a stage of consolidation where whatever peak bone mass you have reached, that particular mass is maintained in females after menopause and in males a little delayed as compared to the females. But there is more loss of the bone than the new bone formation. and gradually a person lands up with a problem of osteopenia or osteoporosis. If we consider the pathophysiology, it can be basically a poor bone mass acquisition during the growth and development. For that, there are various nutritional or endocrinal factors involved. Or it can be accelerated bone loss after the peak bone mass is achieved. So you have achieved the peak bone mass, but the bone loss is a little faster. Both the processes are modulated by environmental, that is nutritional, behavioral and medication factors, and more important, genetic factors and hormones, mainly the estrogens in female. The bone tissue is divided into two types. One is cancellous and the cortical. And the cancellous bone has a structure like a sponge. There are a number of trabeculae, and the trabeculae have their own thickness. The osteoporotic changes are more pronounced in the cancellous bone, more pronounced than the cortical bone. And what happens is there is a reduction in the number of the trabeculae, and the trabeculae become more and more thin. So this is a diagrammatic representation. You can see that the normal thickness of the trabeculae is like this. From that, it becomes so thin, looks like a honeycomb. This is a architectural design of a vertebral column, wherein normal bone and an osteoporotic bone can be very clearly seen. In the cortical bone, the changes are in a different form. There is enlargement of the medullary canal. There is a thinning and weakening of the cortex, because of which there is a poor hold of the screws that you put in if there is a fracture. And whenever there is a fracture, because the cortex is very thin, there is always very severe comminution. This is a good old Singh's index, which is one of the greatest contributions of that time by one of the Indians, Dr. Professor Maini from Delhi. And he has described when all the sophisticated modalities of diagnosing the osteoporosis was not available. From the X-ray of the hip, you can judge the severity of the osteoporosis by looking at the pattern of trabeculae. You can see the tension trabeculae which is going from the trochanteric area to the head, and the compression trabeculae going from the calcar into the head, which are in continuity with the trabeculae into the sacrum. So if you see the number of trabeculae from grade 6 to grade 1, you can see how the number of trabeculae gone diminishing. And this was one of the best methods to judge when the sophisticated modalities were not available at that time. There are some nutritional factors like dietary calcium intake inadequacy, vitamin D status, protein intake, calorie intake, and trace elements like phosphorus, vitamin C, K, copper, zinc, and manganese. They also play a part in the constitution of the bone mineral density. There are some behavioral factors and medications like physical activity, smoking, alcohol, excess thyroid hormone, use of heparin for different cardiovascular conditions, then use of methotrexate for either rheumatoid arthritis or some malignancies, phenobarbital, phenytoin for epilepsy, and steroids for so many other conditions. So if we see the pathogenesis of osteoporotic fractures, there can be low peak bone mass, there can be postmenopausal bone loss or age-related bone loss, which ultimately results into low bone mass. There are other risk factors which are also contributing to low bone mass. Then there are non-skeletal fractures which are responsible for increased propensity to fall, like visual impairment, the auditory impairment, and neurological conditions. And there is a poor bone quality. So low bone mass plus these factors put together, there is a high risk of fracture. And this fracture can result with very low velocity injury. So low BMD is equal to reduced peak bone mass or increased loss. Osteoporotic fractures are mainly seen in the vertebrae, hip fractures, and lower end radius. And these fractures are markers of the future fracture risk. There are many which occur with everyday activities like lifting, pushing, or very simple trivial falls like just skidding in the bathroom. This is a very interesting study which has been published, that how much force the vertebral body takes. Action of bending the back or bending from the spine, there is a weight of 200 to 300 kgs of force is imposed on the vertebral body. The normal vertebral body in a young patient can withstand the force of over 1000 kilograms. In osteoporotic bone, the density and the strength of the vertebral body is decreased respectively to about 70% of bone density and 50% of the bone strength. The strength of the vertebral body against the load applied to the low back in daily living activities is reduced, and it makes it vulnerable for a fracture. As far as the backache with osteoporosis is concerned, what are the causes? Number one, slow deformation of the vertebral bodies because of the very weak and fragile bones. There can be a acute fracture. There can be a hypersensitivity to pain. There can be associated degenerative changes like facet joint arthritis and disc degeneration. And deformities in the spine in the form of kyphoscoliosis or just kyphosis, which can change the mechanics of the spine. There are different signs and symptoms by which the patient can present. The clinical expression of osteoporosis is basically a skeletal fracture, which is an acute presentation. The vertebral fractures most commonly go undetected in majority of the patients if there is a very slow process of collapse. Patients may complain of just vague back pain and increasing kyphotic deformity. And on investigation, you find that there are multiple vertebrae which are gradually becoming wedge-shaped. And this is a very slow process of collapse of the vertebrae. Or there can be a trivial fall resulting into fractures of the hip or lower end of the radius. For the diagnosis of osteoporotic fractures or osteoporosis, history and physical examination is very important. One has to identify the primary and secondary causes of osteoporosis. And one of the basic investigations you have to do is X-rays, wherein in cancellous bone, you find the reduced number of trabeculae, and in the cortical bone, you find thinning of the cortex. If you do bone mineral density, then the density is reduced. And in lab investigations, you may get associated findings of reduced vitamin D levels or reduced calcium phosphorus levels, which can be additional contributory investigation finding that you can get. The history of clinical risk factors. There can be loss of height because of slow compression. There can be low body weight. There can be advancing age, late age of at menarche, menopausal history, time since menopause. I think as the time is more and more after the menopause, the porosis goes on increasing. The factors like smoking, then dietary intake of calcium, the consumption of alcohol, different kinds of medicines which we have seen and they were enlisted into the list before. Then inflammatory diseases which can cause osteoporosis like rheumatoid arthritis or other collagen diseases, and history of any prior fragility fracture. I think these are some clinical risk factors which we have to look for. In the physical examination, the findings suggesting increased fracture risk are impaired ambulation. Just impaired ambulation itself can give rise to osteoporosis because of inactivity, muscle weakness, impaired balance, and reduced vision. The signs of prior fracture like loss of height, kyphosis, chest deformity, or rib pelvic overlap also should be observed in physical examination. So these are very typical pictures that you see in all osteoporotic spine problems, that a person standing straight touching the wall, you can touch your thoracic spine, buttocks, and the occiput at the same time if you don't have kyphosis. And when you have kyphotic deformity because of osteoporosis, the distal distance between the wall and the occiput goes on increasing, and you cannot touch the occiput when you are touching your spine onto the back, on the wall. And the rib pelvic distance, because of the kyphosis, the ribs start coming down, and the rib pelvic distance becomes less than 2 finger braids, which indicates that there is a definite collapse of the vertebrae. There are certain tests that one does for doing diagnosis or confirmation of osteoporosis. The commonly done test, which is many a times done as camps in various hospitals, is USG investigation to diagnose the osteoporosis, wherein under the USG machine, ultrasonography, you can have a look at the calcaneum and or lower end radius, and that can give you a rough idea about how much is the osteoporosis. But it is not really an accurate method, because we have seen that when these kinds of camps are conducted, even young individuals, when they just at random go for the checkup, they are also reported number of times osteoporotic. So I think not a very reliable test to do. Metacarpal thickness index again is a test which is based on the X-ray finding of the thickness of the metacarpals of a non-dominating hand. It's comparatively a much accurate information that you get, hardly about 5% or 10% variation as compared to DEXA. And because this is based on a radiology, that is why you can get a fairly good idea about how much is the osteoporosis. The gold standard today is the DEXA scan, and something which is new, especially for the spine and the hip, is a Q scan or quantitative CT scan. This is something which is coming up new, and I'll have some additional information about it in the coming slides. DEXA is a dual energy X-ray absorptiometry, which is done for central and peripheral parts like spine and hip, and then you can do it for the radius also. In this, you get the X-ray picture of this particular area, and in the spine from L1 to L5, every vertebra you can judge how much is the bone density, and you can get in the hip also, you can get the density of the trochanter, you can get the density of the neck, so that you can get much better and accurate information than just getting a metacarpal index. The common sites for DEXA are centrally vertebrae and hips and peripheral distal end of the radius. And based on the findings of the DEXA scan, you have to label the patient as osteopenia, osteoporotic, or severe osteoporosis. The T-score is the number of standard deviations patient's BMD is above or below average of BMD of a young adult reference population. And this T-score is the indicator used in adults. But if you're comparing with a pediatric population, then instead of a T-score, you have to use a Z-score. So the report of a DEXA scan gives you T and Z score, and you have to accordingly use it for particular age. What is the clinical utility of a bone densitometry? You can understand the severity of osteoporosis, and if you have to treat an osteoporotic fracture, if the osteoporosis is less than minus 3.5 T-score, then you know that any implant that you put in is likely to fail most of the times. So you have to take care of choosing an implant, especially if you use a surface implant, it is likely to fail in many of the patients. Similarly, if you are treating a spine with osteoporosis, and if you know that the score of the BMD is minus 3.5 or more, then you know that just giving calcium and vitamin D is not going to be enough. You have to go for some more higher drugs like teriparatide, and how long you have to give. So there are some guidelines about which we will discuss, and that gives you an idea about what kind of treatment modality you are going to use. Secondly, by doing bone density, if you are putting the patient on anti-osteoporotic treatment, after the treatment is over, say by about 1 year, 1.5 years, you can repeat the bone density and you can understand how much is the response to the treatment that was given for the osteoporosis in that particular patient. So that gives you monitoring of the treatment and the improvement of the patient. A word about the quantitative CT scan. This is primarily used to evaluate bone mineral density at the lumbar spine and hip. This is used in the diagnosis and monitoring of osteoporosis. Lumbar spine, the measures of BMD of only spongy interior bone separately you can get by the quantitative CT scan. The trabecular bone has a higher metabolic activity than the cortical bone, and it is affected by age or disease or therapy related changes earlier. The quantitative CT has an advantage that it can give you earlier changes in the bone mineral density than the bone density BMD DEXA scan. Why it is important? Because whenever there are sclerotic changes because of the facet joint hypertrophy, or there is a calcification of the vessels into the abdomen which overlaps, many times DEXA scan can give you a very abnormal reading. Though you can obviously feel that the patient is osteoporotic, the T-score may not be that bad, basically because it cannot differentiate between the overlapping structures like the facet hypertrophies with sclerosis, and that can mislead you. So it enables the spine BMD measurements in patients with scoliosis also, which cannot usually be measured using dual energy X-ray absorption or DEXA scan. Because in a scoliotic spine, because of the sclerosis, again, you can get completely wrong readings by only DEXA. And as I have already mentioned, it avoids false high BMD values from patients from arthritic spine, or because of obesity, or because of the calcification of the vessels. There are some lab investigations which are necessary for secondary osteoporosis. You have to do hyperparathyroidism studies like PTH, serum calcium, then thyroid function test for hyperthyroidism. Then for hypogonadism, you have to do levels of the hormones like testosterone or estradiol. Then for osteomalacia, you have to do vitamin D levels. For Cushing's, you have to do 24 hours free urinary cortisol and dexamethasone suppression test. Then for renal functions, you must know what is the serum creat level, glomerular filtration, and according to the new standards, eGFR, which should be more than 90, because that is a more accurate indicator, eGFR, than just knowing the creatinine. Then for liver diseases, you have to do the liver function test. For malabsorption, you have to do 24 hours urinary calcium excretion, serum albumin levels and calcium levels. For myeloma, you have to do Ben-Jones proteins and serum electrophoresis. For rheumatoid tibulopathy, urine analysis including pH, acid-base studies, urinary calcium, phosphorus, and amino acid. And for inflammatory diseases like collagen disorders, you have to do ESR, CRP, and anti-DNA antibodies or rheumatoid factor test. After diagnosing the patient as osteoporotic patient with spine problem, you have to understand what is the management. For acute low back pain, bed rest is very important. Till the time the patient's acute pain settles down, advise him bed rest. Anti-inflammatory analgesics, you can give calcitonin injections or calcitonin nasal sprays, which are having not only effect of improving the porosis, but they have good analgesic action also. Then subacutely progressing vertebral deformation after occurrence of vertebral fracture, if you have noticed, then you should give orthosis. You can give a Taylor's brace. Nowadays, you can get good quality ready-made Taylor's braces available on the counter, and you can prescribe a Taylor's brace which can give a support to the entire spine and try to maintain the normal curvatures of the spine. For hypersensitivity to pain in especially postmenopausal women, calcitonin also has a very good effect. As far as the chronic low back is concerned, there is a deformity of the spine, mainly in the dorsal spine, giving rise to dorsal kyphosis. You have to give symptomatic relief with anti-inflammatory analgesic drugs. You can inject local steroid with local anesthetic in a trigger point, which can give rise to a good, quick relief to the patient from his pain. And then the physical therapy as low frequency diathermy or high frequency diathermy and local heat to the erector spinae muscles and to the lower and upper back, that can give a symptomatic good relief. If there is an instability of the spine due to fractures in osteoporosis, then you have to go one step ahead. Even in the fractures due to osteoporosis, the vertebral body can be severely collapsed, resulting in a disturbed stability. And many a times, these osteoporotic vertebrae, in spite of getting collapsed, do not heal. So you see something called as a vacuum sign. You can see actually there is a black line in the vertebral body when the vertebral body has collapsed completely. And if you take flexion extension views, then you can see that the vertebra opens up, indicating that it has gone into non-union. And this can happen in as early a period as just 4 or 5 months after the compression fracture. The surgical treatment has to be considered in these cases where there is an excessive collapse or non-union, resulting into instability and continuous pain. What are the surgical options? You can do a vertebroplasty. You can put bone cement. There is a special cement available called as a vertebroplasty cement, which has got a longer setting time of about 20 minutes than the regular cement which we use for the joints. And that in a liquid form can be injected transpedicularly into the involved vertebral bodies. And this procedure can be done if the patient is able to lie down prone in the operation table. And you can do it under local anesthesia. And if there is a leakage of the cement, or if there is irritation of the nerve root when you are going through the pedicle, the patient being under local anesthesia can give you immediate hint that he is getting some irritation to the nerve. But this is one of the excellent procedures by which you can get very good relief of pain. Then you have to extend the fusion segments. If there is a vertebral compression at 1 or 2 levels, you have to span the compressed vertebrae by going 2 levels above, 2 levels below, and you can extend that fusion so that the pain relief is excellent. And instead of doing fixations on only one side of the pedicles, it is better to do bilateral fixation and put a cross link in between the two, so that it makes the assembly much more stable. One can add in difficult situations sublaminar hooks, and you can use a combination of hook and pedicle screw assembly, which can give you additional stability. A word about vertebroplasty or kyphoplasty. As I said, by transpedicular approach in vertebroplasty, needle is put into the vertebral body. The position is confirmed under the image intensifier on both the AP and lateral views, and then you can inject about 1 to 2 cc's of bone cement, vertebroplasty cement, either from one side or from both the sides. If you can do that, that gives a nice expansion of the collapsed body. Not as good as kyphoplasty, but many a times in a prone position, the vertebra opens up, and in 20 minutes time, the bone cement consolidates and the patient gets immediate excellent relief. The patient who has come on the trolley into the operation theater can go back from the table walking. So it's an excellent procedure. There are some plus and minus about it. If the vertebra in which you have injected the bone cement becomes too hard, then sometimes in very porotic bones, you can get adjacent level compression fractures without much trauma. So you have to guard the patient from the activities and give a talus brace support even if you have done a vertebroplasty. In kyphoplasty, instead of directly injecting the cement, you can use a balloon which goes and gets inflated into the vertebral body, and then you inject the cement so that the chances of extravasation are also less, and the balloon inflates and can get better correction of the deformity in a compression fracture. This is an example of a patient undergoing a vertebroplasty. You can see that the cement is going in the vertebral body, and this particular procedure can be done even at 3-4 levels because you're injecting hardly 1.5-2 cc's of cement in every vertebra. This is another example. You can see a vacuum sign like gap into the vertebral body, and you can see how the cement has expanded that particular vertebral body after injecting through the pedicular route. This is another example wherein again the cement has expanded the body, and the patient got excellent relief. This was an 85-year-old patient. After knowing what kind of treatment you can give for the compression fracture, one must know how to prevent and what are the treatment goals. If you have stabilized the fracture, or if you have increased the bone mass, then you have to maintain or you have to improve the bone quality by putting the patient on the exercise program, proper nutrition, and prevention of falls so that he doesn't land up with another fracture. As far as the fracture management is concerned, we have already seen you have to relieve the pain, you have to stabilize the fracture, restore the anatomy as much as possible, and you have to manage the comorbidities because of which the patient can land up with another fracture. In these patients, a psychological support also plays a very, very important role. Non-pharmacological management like adequate intake of dietary calcium, vitamin D, proteins. Nowadays, we have seen that even in younger population, vitamin D deficiency is rampant. And we really don't know whether it's a pharma-driven thought that is coming up that vitamin D is low in everybody, or it is a real situation that because of the pollution, we are really not able to get enough ultraviolet light on our bodies, and we are not able to manufacture our own vitamin D. The Indian diet as such is not at all very rich to supply vitamin D through a dietary source like fish oil or anything. So I think Indian population, we have a major problem of vitamin D deficiency, and we should be aware about it. One should avoid smoking and excess of alcohol, and prevention of fall as a preventive method is also a very important method. There are certain things that you can do in the houses of the patients where there is a problem of osteoporotic spine. Number one is correct the visual and hearing impairment, because many a times that contributes to a fall and they can land up with a compression fracture. So that one particular correctable factor should be corrected. Optimize the medication. Then in the bathrooms, you can have the grab bars, or you can have a non-skid mats, which will prevent the chances of fall. Avoid putting carpets or slippery mats into the rooms and in the bathroom doors. Then keep the electrical and telephone cords away from these people, because they can many times just get entangled into these cords and they have a fall. Reduce the clutter from the walking areas. Keep the walking areas clean. It is very necessary to keep light during night in the room as well as in the bathrooms, so that because of lack of proper vision into the surrounding, they don't land up with falls. It is very necessary as and when possible to put the handrails on the steps and stairs, and you should encourage them to use walking aids like walkers or sticks, and exercise as much as possible, because many elderly patients, they are very reluctant to do any exercise. So it is very important to motivate them by explaining to them what is the importance of exercise by which they can strengthen their muscles and indirectly the bone, and they can improve their balance if the muscles become strong. The pharmacological treatment, in addition to calcium, vitamin D, you have to supplement with proteins. Then there are different drugs which are available now. The bisphosphonates, calcitonin, denosumab, these are the drugs which act by the way of reducing the osteoclastic activity. But many times, these drugs are used very indiscriminately. If the patient is already having severe osteoporosis, then just giving drugs by which you can reduce the osteoclastic activity doesn't improve their condition. Because it is like, if you want to become rich, stop spending money. But then if you don't have money before, by just not spending the money, you can't become rich. So you have to earn money first, and then you don't spend. Then you can become rich. So bisphosphonate should be used only when the bone density has already improved by teriparatide. So I think teriparatide, especially if the T-score is below -3, should be the drug of choice, unless there is some contraindication like renal compromise or any other medical issue by which you are prohibited from using the teriparatide. And anabolic steroids, they also have role, but that too also, if you have built up the mass, then anabolic steroids have a better role. As far as use of calcium is concerned, there are a number of salts available in the market, and many of them, they contain calcium carbonate. But I think we must understand what is the absorption rate of the calcium carbonate and calcium citrate or calcium citrate malate or calcium orotate. These are the salts which are more soluble. They have more elemental calcium which can get absorbed. So the bioavailability of the calcium from these salts of calcium like calcium citrate or orotate is much better, and they can give much better outcome of calcium treatment than giving preparations of calcium carbonate. We must know what is the daily requirement of calcium at various ages. And as we are basically dealing with osteoporotic spines, the main in the age group of 50 to 70, the minimum requirement is 1000 and the upper limit is up to 2000 milligrams per day. And men over 70, it can be from 1200 to 2000. And women also have almost the same requirement. So I think we have to compensate for this particular need of the calcium requirement of these patients. And ideally, you should tell them, I have seen some doctors writing this calcium for lifetime. That's the real truth in many of the elderly patients, that you have to take it throughout the life. The low calcium intake and vitamin D deficiency should be corrected in all the patients. In patients with low calcium intake, calcium alone induces small increase in the bone mineral density and possibly reduces some fracture risk in these patients. Calcium and vitamin D supplementation in women living in nursing homes decreases the hip fracture incidence. Vitamin D daily maintenance dose is about 1000 to 2000 international units, or about 60,000 units in a month, or 60,000 units every 15 days as a maintenance dose, and that should be regularly administered at this age. As I have already given an example, that if you want to become rich, you have to earn the money first and then you store it or you don't spend it. So build up the bone mass with teriparatide, and then you can use bisphosphonates and calcitonin and the anabolic steroids by which you can maintain that bone mass that you have already achieved, and that will give you a long-term relief. In situations where teriparatide is contraindicated, you can take help of denosumab, which is again a subcutaneous injection which can be given once in 6 months and has got good results. In many malignancy patients, this drug has made a lot of difference in the patients who are having risk of pathological fractures. As I said, bisphosphonates basically anti-resorptive. So indicated if the T-score is between say -1 to -2.5, you can use directly, and that reduces the absorption. There are various preparations available like alendronate, risedronate, ibandronate, zoledronic acid, and we must know what are the side effects of them. In oral administration, GI intolerance and flu-like symptoms like myalgia, arthralgia, fever is seen. In intravenous, when you're using zoledronic acid, again, one can get myalgia, arthralgia. In 12 to 48 hours after application, they get these symptoms, and that can last for 1 or 2 days or sometimes for 1 week. And many times to control that, you have to give steroids. Some patients can land up with hypocalcemia, and they can land up into a picture like tetany. Some have ocular problems. Some of them have renal dysfunction. And on long-term basis, when you have used it for more than 3 to 4 years, you can have osteonecrosis of the jaw and atypical fractures of the femur, which is one of the very difficult conditions to treat. Serum calcium and serum creatinine is mandatory with IV bisphosphonates. Calcitonin nasal spray or calcitonin injections, again, they are anti-resorptive. BMD can increase slightly. The fracture risk is minimally reduced, and it has got a very good analgesic action. So in addition to the anti-osteoporotic, in acute pain, number of times that has got an advantage of giving analgesic effect. As I said, the drug of choice, if there is no contraindication, is teriparatide, especially if the T-score is less than 3, and it has got definite osteoblastic activity, and it improves the quality of bone by new bone formation. Occasionally, the patients do get some dizziness or some leg cramps in few of them, but overall tolerance to this drug is quite good. You should continue giving this drug for at least 1.5 years. Sometimes you can extend it even up to 2 years safely, and that definitely has a good role in improving the quality of bone. Denosumab, as I said, has again action like preventing the osteoblastic activity, but because it is available as one dose every 6 months subcutaneously, this can be another good option instead of giving oral or IV bisphosphonates in patients of osteoporosis. The hormonal therapy, which is the age-old treatment which was given in the postmenopausal osteoporotic females, they used to give estrogen patches and some oral medication containing estrogen. That also has some role, but looking at the side effect of these drugs, especially the carcinogenicity, these drugs have gone back into their use. Then there are selective estrogen receptor modulators like tamoxifen and raloxifene, which can be used instead of estrogen, and they also have a definite advantage in postmenopausal osteoporosis. Then isoflavones, which are naturally occurring substances which are present in many beans, especially soya, acts as phytoestrogens in mammals and can be used as estrogen replacement. It is a potential in increasing bone resorption and decreasing bone resorption and enhancing the bone formation. So these isoflavone containing preparations are also available in the market and you can use them. In summary, the different therapeutic options include several anti-resorptive drugs and more recently new anabolic compounds. Bisphosphonates reduce fracture risk for vertebral and non-vertebral fractures. And anti-fracture efficacy is already evident after 1 year of treatment. Raloxifene has skeletal effects similar to those of estrogen and reduces vertebral fracture risk. Parathyroid hormone treatment induces significant increase in the bone mass and decrease of fracture risk. And in postmenopausal women and low bone mass, denosumab increases bone mass and decreases the bone resorption and reduces the fracture risk. force imposed on the vertebral body, because we are not talking only about the treatment part, but we have to think of um, the preventive part of the fracture, as the the basic theme of this webinars is concerned is healthy lifestyle. So we must think about the preventive measures to prevent osteoporosis and the osteoporotic complication. So the force imposed on the vertebral body greatly varies depending on the daily living activities. And when a strong force is imposed on the muscles of the back, the load on the vertebral body tends to increase. The load on the vertebral body can be reduced by avoiding certain sudden movements in stretching or bending the low back, and in lifting something from the floor, and by trying to move gently and in a good muscular balance. To prevent a fracture due to osteoporosis, instructions on daily living activities, in addition to increasing bone strength, is also very vital. So in conclusion, well, every person above the age of 45 years is prone for developing osteoporosis, which is a natural physiological change taking place in every body. But as we know more and more about osteoporosis, I think we know how we can prevent development of osteoporosis. So one should do adequate exercise, especially muscle strengthening exercises, by which the osteoporosis can be definitely prevented or minimized. And proper dietary supplement of calcium, vitamin D, and proteins and trace elements is also an equally important part to take care of the health of the bone. If osteoporosis is suspected, then you should do a DEXA scan, and if you are able to catch them early, by a simple treatment, you can correct that osteoporosis and prevent the further complications. So if you know the grade of osteoporosis, now you have a choice of different medications available by which you can treat the osteoporotic spine and you can relieve the patient from the agony. I think thank you very much for this opportunity to share my views on osteoporosis. And I think it's an evolving subject, and things are going to come up by which probably we'll be in a better position to treat osteoporosis in the coming years. Thank you. Thank you very much.
Thank you, sir. Thank you for your nice informative talk. Dr. Gadegone.
So thank you, Kakatkar sir. You have given a wonderful talk on each and every aspect of osteoporosis. And we are discussing this topic since yesterday. It's because it is very important and pertinent. And there are so many confusions regarding the management of this condition. So actually, most of the points are, I think, they are cleared. And anything if remains, we will discuss after the Shrikant Tamhane's lecture is over, so that we are here only and we can discuss in a better way. So over to
Arjun.
Arjun. So you can introduce.
Sir, one question.
Yes.
Sir, regarding vitamin D use, we used to give, or we use a weekly dose of 60,000 K units. Nowadays, they are promoting the dose like we should give it daily rather than weekly. And most of the companies are also saying that for chronic backache and all, we can give continuous 60,000 K for 10 days or so. So what is your take on these different opinions? How we should go?
See, I think there has been a lot of change in the administration of vitamin D in the last couple of years. There is an organization called as Osteoporosis International, and they have done a lot of work on how vitamin D should be used. Initially, when the vitamin D levels used to be very poor, they used to recommend injectable vitamin D, 6 lakh units as an oily injection into the buttocks. But in the last couple of years, the concept of giving injectable vitamin D is almost given up unless there is some major GI problem. The vitamin D, even in 6 lakh units ampules, is now given in the oral route because they have found that the injected vitamin D, being a fat soluble vitamin, many times to reach the peak levels after getting absorbed into the fat of the buttock where you are injecting it or the thigh, the peak levels reach very late. So as compared to that, if you give it orally, you can get the peak levels earlier. That is what has been studied in number of places. So I think that is one first change that has happened in the last couple of years, that vitamin D, even the arachidol injection, is given orally. Now, as far as giving daily or weekly or monthly, if the levels of vitamin D are below normal, that is, if you consider 30 as the lowest level normal, if you find that the levels are just say about 15 or 20, then I think every week 60,000 units is what is recommended. Till you are able to come to a level where your vitamin D levels are about 45, 50 at least. And then you can maintain that by giving the vitamin D dose of 60,000 units once in 15 days, or depending on the levels that you have achieved, you can even give it once in a month. So I think giving it daily number of times is useful if you combine it with some preparation of calcium, because there are number of preparations where there is 1000 unit of vitamin D along with calcium as a combined preparation. So if you use it that way, then in one tablet you can give both the medications and you can use that route. But otherwise, as far as only vitamin D is concerned, I think even once in a week or once in 15 days, once you have achieved the proper levels, is I think good enough. I think Dr. Shrikant will be able to throw some more light as an endocrinologist on this topic.
Thank you.
Yeah.
Yeah, I
Sandeep,
take this opportunity to request Dr. Shrikant also to give a comment on this about the doses of vitamin D. Your comment.
Yeah, thank you. So excellent question. And as Dr. Kakatkar rightly mentioned, so vitamin D administration. So in US, we don't have any parenteral way of administering. So we do give oral medication. So what we have seen with administration is, so the only kind of problematic dose was the 500,000 or more given at a single time. That has been seen to have increased risk of falls and fractures. So apart from that, any other dose below that has not necessarily shown in studies to have any adverse effects. So the way we do it here is, it's just most of terminology used. So maintenance dose versus loading plus maintenance versus just keep giving it weekly or monthly. So, it's mostly a discussion with the patient is how they prefer to do it. We prefer to do it daily because it's close to more physiological replacement. So giving it daily, so usually that will be the D3 preparation. Weekly or monthly, the 50,000 or 60,000, that will be the D2 preparations. Either is fine. So it's we prefer daily, but if you want to give it weekly or monthly, that's fine. What dose to give, it just depends on what level you're starting with. As Dr. Kakatkar rightly mentioned, so we target usually keeping the levels above 30. So our target is to keep it mostly between 30 to 60. So that's the aim. Depending on where you're starting, we start with a particular dose of daily and then check it after 4 to 6 or 8 weeks, see where the dose is achieved. Again, depending on when you're checking it, is it at the end of summer, end of winter, the levels may vary a bit, but that's the goal. And preparation wise, daily, weekly, monthly, either is okay, depending on what the patient prefers.
Thank you.
So it is indeed, yes, I'd like to introduce Dr. Tamhane to you all. It is indeed an honor to welcome and introduce Dr. Tamhane straight from Arkansas to the United States of America, where it is currently 7:30 in the morning. And we have with us an internationally acclaimed endocrinologist who has authored several highly cited publications in top peer-reviewed international journals. Many of his publications are part of the Endocrine Society guidelines even today. Dr. Shrikant Tamhane completed his MD in internal medicine from the MedStar Good Samaritan Hospital at Baltimore, and thereafter did his endocrinology fellowship at the Mayo Clinic in Rochester, North America, where he continued to work as an assistant professor. He went on to do his MBA in healthcare at the Duke University out of his interest in improving the healthcare system in the United States of America. Today, Dr. Tamhane is a consultant endocrinologist at the Baptist Health Specialty Clinic at North Little Rock, Arkansas. We are honored to have you with us, dear sir, and even though it is so early in the morning, you've taken the trouble to be with us. We look forward to hearing from you.
So I also wish Dr. Karne to say something about Dr. Shrikant Tamhane.
Well, Dr. Shrikant Tamhane is actually from Pune, and he has done his MBBS in Pune, and he stood 10th in the whole state in the merit list there. And then for post-graduation, he went to US and then he got settled there. And he's right from childhood, he is known as an excellent, highly academic and methodical person. And whatever he does with a passion and with a deep study. And then he has worked at the Mayo Clinic also. He was given a respectable post there at that time at a very young age. And in his department, rather his own boss was a chief of the Lancet. He was in the director board. So he's in a highly academic environment, and we hope that we'll get the best possible information as far as we'll say day-to-day issues of the orthopedic surgeons which we are facing. We know so many medicines, we know so many medicines for this and osteoporosis, but we don't know what to give to the next patient. So, and when to give. I mean, how the patient should be evaluated to give the different medications and how long one should give it. And whether it is a hype of the osteoporosis which is there going on because of the forces of the company, or it is a you can say rather less awareness among the orthopedic surgeons. They are not paying much attention to the osteoporosis. These are the two extremes. So we want to know from him what is the current status of the osteoporosis, especially from orthopedician's point of view. Thank you.
Thank you.
Over to Dr. Shrikant.
Thank you. I'll just share this. Thank you so much for the kind introduction. That's very kind words. Thank you for Maharashtra Orthopaedic Association for giving me this opportunity to speak with you all. So in another 30 minutes or so, which is the time given to me, this will be a very kind of broad level brief overview of osteoporosis. And I'll be happy to take questions if there is anything specific that you wanted to know. So we'll mostly talk about I'll speak about osteoporosis screening and the definitions as well. A lot of topics have already been covered by Dr. Kakatkar, so that was an excellent talk. So I will try not to overlap and not to duplicate things. We'll talk about things which will be slightly different. We'll talk a bit about bone mineral density, and I'll touch briefly about a tool called FRAX as well, which we use quite often. We'll talk about the candidates for treatment options, and also speak about some of the newer therapies which are still probably not available in India, which we use here quite often. And I'm pretty sure they'll be available in India very soon. So as was mentioned earlier as well and shown, so this is a nice electron micrograph picture of how the bone looks with osteoporosis. So on the left is the normal bone architecture, on the right would be the bone with osteoporosis. So as mentioned, trabecular thinning and architectural defects will be seen. This was also mentioned earlier. So a very nice and important graph to remember as well as how you think in terms of the bone mass acquisition and then loss. So in the initial few years, as was mentioned earlier, so there'll be a phase of bone mass growth. And then as you will see, roughly around the time of menopause, there'll be a steep decline and it will continue to decline. So osteoporosis, what is the significance? So now these are US numbers, but the numbers probably are very similar and in proportion in India as well. So roughly about more than 250,000 hip fractures annually, with 20% excess mortality within the first year of fracture. So this is very significant. So high morbidity and mortality after the hip fractures, significant functional loss for those who survive. More than 500,000 vertebral fractures with loss of height, chronic back pain. The topic was excellently covered in the prior talk. Again, 80% are women, but not to forget, there is about 20% in men as well. So this is often a neglected or forgotten factor, osteoporosis in men. Now, this is a very striking graph, which I always, when I'm talking with my medical students, residents or fellows, or, with the patients. So a heart attack or a cardiac event. So once a person has it, it's taken very seriously. There is a lot of things done after the cardiac event to prevent the second event from happening. So a hip fracture is similar to like a like a cardiac attack, it's a bone attack. So once that happens, a fragility fracture happens, it's if you compare the statistics, it's very interesting. It's very similar to what we see after the cardiac event. So the risk of having the second event within the first year, same as cardiac event, is close to 20%. So statistically, things are very similar. But unfortunately, in US as well as all over the world. So osteoporosis, or making sure that the second event doesn't happen, things are not done in a more aggressive fashion. So in US now, at many places, there are osteoporosis teams in the inpatient setting as well. So if a patient gets admitted with a hip fracture, so typically the patients don't leave the hospital unless they are either got into a bone clinic or something is done about thinking about the treatment for osteoporosis in those patients. So and as I mentioned earlier, so the most common fracture sites due to osteoporosis would be the distal radius, the Colles fracture, lumbar and thoracic vertebral fractures, femur neck, intertrochanteric fractures. So any other fractures except for fingers, toes, and skull would be considered osteoporotic fractures. Now, I'm talking to a group of orthopedic surgeons mostly. So you're going to see what happens when we are at the point of already the event has happened. But the aim or goal is to see if we can reduce or prevent these events from happening. So that's where the screening part comes into play. And as the name suggests, his goal is to identify people who are at an increased risk of sustaining a low trauma fracture and who would benefit from interventions to minimize that risk. So as mentioned earlier as well, so history and physical examination to assess the risk factors is important. Bone mineral density is an important tool in the assessment as well. So in US, the majority of the groups recommend bone mineral density assessment in postmenopausal women, 65 and older, regardless of the risk factors. Now, if you have the clinical risk factors, then we should be assessing early as well. So what are some of these clinical risk factors which are independent of bone mineral density? So advancing age and previous fractures, these are two quite significant and important risk factors. So apart from those, patients who are on chronic glucocorticoid therapies, parent history of hip fracture is an important determinant of risk of fracture. Low body weight. So, we typically jokingly say, so as endocrinologists, we see a lot of patients with diabetes. So essentially low body weight or having a, not being overweight or obese helps with a lot of other metabolic problems, not so much with the bone health. So low body weight is a risk factor actually. So cigarette smoking, excessive alcohol consumption, rheumatoid arthritis, or any of the inflammatory conditions, so that would be a risk factor. Secondary osteoporosis, as I mentioned earlier as well. So hypogonadism, premature menopause, any malabsorptive disorders, chronic liver disease, inflammatory bowel diseases after transplants. So those would be the clinical risk factors. Now coming to the bone mineral density. So low bone mineral density is a single most accurate predictor of increased fracture risk. So this is a tool that we use quite often for screening. So for every one standard deviation decrease below the mean, the fracture risk roughly doubles at the spine and hip. So the techniques that were discussed in details earlier, so I won't go into the details. So DEXA, as we mentioned, quantitative CT in selective cases, calcaneal ultrasound. So this is, as rightly mentioned earlier, it's not very accurate. So this is the typical DEXA machine or the bone densitometer that we use. So with the typical results for the DEXA, we are usually doing the central or the axial skeletal. It's going to be the spine and the hips. And we could also do appendicular in selected cases, especially if they have primary hyperparathyroidism. So their cortical bone is going to be more affected. So a radial bone density can also be done. So this is the typical report that you will get. So when we assess the spine, I make a point to look at the images always to see if the markers have been placed right, because a lot of times it's the technicians who are placing the markers. If they're not placed correctly, you're going to get, falsely high or low bone densities. So taking a look at that. So for example, in this image as well, you'll see that L4, there is a lot of osteoarthritic changes. So if we take L4 into the calculation as well, it is going to skew your results. So typically the validated scores are mostly when we consider it's composite L1 to L4. So that's what we usually consider. But if there is any vertebrae which is going to skew the results, we eliminate that. So this would be like measuring L1 to L3 and taking the results for that. In the hip as well, so we're going to look at the neck and the total score. Again, the markers are very important. So many times we see that the markers are wrongly placed and that's going to skew it. So taking a look at the images is always helpful. As was earlier mentioned as well, so these are the definition by WHO for osteoporosis and osteopenia. So T-score greater than or equal to -1 standard deviation will be considered normal. Less than -1 to greater than -2.5 will be osteopenia, low bone mass. Or less than or equal to -2.5 standard deviation will be considered osteoporosis. Now, as earlier mentioned, so osteoporosis by definition is a systemic skeletal disorder characterized by compromised bone strength, predisposing to increased risk of fracture. What is very important to understand is when we are assessing for bone strength, it is not only the bone density, but bone quality is also very important. So this is an important factor that you have to keep in mind when you're assessing for bone health with just the bone density. With the DEXA. So DEXA is going to give you information about the bone density. It doesn't tell a lot about bone quality. So this is another assessment that you have to always consider in your mind is, are you assessing the bone quality appropriately? So this would be if the patient has other clinical risk factors. I'll talk about the FRAX tool, which helps us a lot about assessing bone quality. So bone quality reflects the architecture, turnover, the damage accumulation, the microfractures, and mineralization. So FRAX is a very good clinically validated tool. So the way we use it here in US is, so when we do a bone density, when we screen patients, we typically will use the bone density. So if the patient has clear osteoporosis, the T-score 2.5 or beyond, -2.5 or beyond, then we know that this patient would be an appropriate candidate for therapy. So basically what we're trying to assess here is who would benefit from therapies and who would be at a higher risk. So the individuals who are osteoporous or having T-scores -2.5 and beyond on bone density, those would be the candidates. Now the individuals who have osteopenia or T-scores between -1 and -2.5, actually, what we see statistically is most fractures happen in this population because the number of people in this population is large. Now we know what their bone density is with the DEXA. So we want to assess a bit more about their bone quality as well. So that's where we use the FRAX tool. It's used a bit differently in Europe. So in Europe, they use it preliminary as screening, and then they decide based on that if we need to get the bone density. What is very good about this tool is, in most areas or resource poor areas as well, is you really don't need a bone density to make an assessment of the bone health. So I'll just quickly show you how this looks. So all you have to do is just Google in FRAX. The beauty of this tool is it is validated across many regions, across many ethnicities. So all you have to do is choose the population that you're dealing with. So if you choose Asia, India. So these are the factors which we discussed earlier as well. So they are considered as clinical risk factors for osteoporosis. So when we enter in the information, you don't necessarily have to enter in a bone mineral density as well. If you enter it, it's going to be a bit more accurate. But when you enter the information and you hit and calculate, so essentially what it gives you is what's a 10-year risk for having any major osteoporotic fracture or having a hip fracture. And those risks are important because we use these cutoffs to determine that if the patient has what we'll call as a clinical osteoporosis, so say bone density in the osteopenia zone, and if the risk factor is so more than 20% for a major osteoporotic fracture risk, or more than 3% for a hip fracture risk, so then we'll classify this individual as having clinical osteoporosis, meaning it is at a higher risk. And these would be the individuals who would also benefit if we are using therapies for osteoporosis. So whom are the individuals, when we screen them and we determine that mostly conservative management would be beneficial for these individuals. So these would be osteopenia based upon bone mineral density. So as we said, T-score less than -1 and greater than -2.5. And if we, when we calculate the FRAX score on these individuals, if the 10-year probability or combined major osteoporotic fracture risk is less than 3% or 20% respectively. So in these individuals will prefer to do more conservative management than having to think about medications for osteoporosis. So in conservative management, as we discussed, adequate calcium intake. So as was mentioned in the table earlier, so typically, in postmenopausal women, we target about 1200 milligrams of calcium intake. Now that 1200 milligram can come through a combination of your diet and supplements. So often, patients ask us, do I need to take supplements? So the answer is it depends. So if you have adequate dietary intake of calcium, you really don't need supplements. So for example, somebody taking about 4 servings of dairy a day, they're very close to meeting that 1200 milligram requirement. So you don't need supplements if the dietary intake is adequate. But in most individuals, the dietary intake is not adequate, and then you would want to have supplements. We did discuss about vitamin D. So as I mentioned earlier, so we want to maintain a level of 30 and above. Again, there are controversies discussing about what is adequate. So Institute of Medicine says 20 and above. We endocrinologists believe 30 and above. So mostly, we see increased PTH levels at around the level of 25 of vitamin D. So 25 and above would be considered as an adequate level of vitamin D. And, so as you were mentioning earlier, so right now, we are diagnosing a lot of vitamin D deficiencies in India. But, that probably phase came to US about 10 or 15 years, where it was a very big thing, early like 2000s. Significant people were being diagnosed with vitamin D deficiency. Asian population or Indian skin, so we are not as efficient to make vitamin D. So if you're going to check for vitamin D, many of the individuals are going to be deficient in it. So it's more of, I think right now we are diagnosing it more. It has always been there. But, in osteoporosis context, coming back to this context, we want the level to be at least 30 and above. And the way we replace it is, as I mentioned, you can do daily. If the patient prefers a weekly preparation, we'll give it. Here we have 50,000 international units available as D2. We can give it weekly or monthly, depending on what dose is required to maintain the level. So that would be the correct dose for that individual. So exercise, so anything weight bearing is going to be helpful for osteoporosis. Fall prevention, so as earlier mentioned, and some of the interventions which were shown, so very important. If you don't fall, the risk of having osteoporotic fractures would be lower. Smoking cessation and alcohol, discussing about alcohol consumption would be important. Medications, as we discussed, so if at all it is possible to minimize, glucocorticoid therapies, proton pump inhibitors, anti-epileptic medications. So these would be some of the classic ones. Now, coming to the candidates for therapy. So we talked about in whom we would consider conservative management. Now, these would be the individuals where we would consider osteoporosis therapy, or, there has been good evidence to suggest that treatment would be beneficial in these individuals. So these would be individuals having history of fragility fracture. So, as orthopedic surgeons, you would see these patients all the time. So where the event has already happened, now, we are trying to see if we can prevent a second event, or in cardiac context, a secondary prevention. And for primary, where, you don't want the event to happen, you're trying to prevent that event from happening. So the individuals who have osteoporosis based on the bone mineral density measurement, T-score less than or equal to -2.5. And we talked about the FRAX. So high-risk individuals with T-scores between -1 and -2.5. When you calculate the FRAX, the 10-year probability of hip fracture more than 3%, or combined osteoporotic fracture more than 20%. So any and all of the individuals who fit in this criteria would be the candidates for therapy who would benefit from osteoporosis medications. Now, osteoporosis medications. So we have a big list of medications. Fortunately, we have a lot of options available. Many a times, there are multiple factors which go into consideration of which would be the most appropriate therapy for a particular patient. So not only the T-scores, the other clinical factors, side effect profile, patient preferences. So multiple of these would play into the decision making. So, as Dr. Karne rightly mentioned, it's usually not a single answer which is going to be a correct answer. So we could have, multiple choices which we could use for the patient, but these other factors are going to determine the choice. So what I've highlighted here is, so the ones in the white are what we call as anti-resorptive medications. And the last three would be anabolic. So from the earlier talk, so I understand that teriparatide or Forteo is available in India. So we also have abaloparatide, which is also a PTH derivative. So it's available for about 5+ years now in US, very similar to teriparatide. I'll talk a bit about that. Romosozumab is the latest addition in, and we are very excited about this agent. I'll talk briefly about this one later on. But if you look at the therapies, so with the bisphosphonates, so the earlier class of this medication, so alendronate, risedronate, ibadronate. So either we can do it orally. So most, we typically, preferentially use alendronate 70 milligrams weekly, preferentially because, there's more data easily available, generic, cheap. Risedronate also we do use if a patient prefers a monthly preparation. Ibadronate, we don't use it as much because the data so it does have efficacy on the vertebral fracture prevention, but it did not show efficacy on the hip fracture prevention. Now, the intravenous bisphosphonate zoledronic acid is the agent that we use here, 5 milligrams IV infusion every year. Okay, let's talk. So raloxifene is the selective estrogen receptor modifier. In select patients, so the efficacy is weak. Again, it hasn't shown efficacy on hip fracture. So we don't use it as a first-line agent unless, so if there is any contraindication, a patient cannot use the other agents, then we could use raloxifene or tamoxifen in the right context. So if the patient has a high risk for breast cancer, using tamoxifen, so that will be helpful as well. So calcitonin, we don't use it as a first-line agent here. One is the efficacy is low. It's not very efficacious in fracture prevention. Again, not strong data on the hip fracture. We do use it in individuals who have the pain after the fracture. So, as mentioned in the earlier lecture, it does help with reducing in the pain. So if that is the condition, then in some select patients, we might use it. And I'll talk about denosumab as well. So two broad classes of medications for osteoporosis. So what we call as anti-resorptives or anti-catabolic agents. So the major mechanism is, so increased bone mineral density. This is a minor factor, but mostly it's preservation of architecture. So as the name suggests, reducing the resorption. They don't affect much with the bone formation side of it. So bisphosphonates that we talked about. So alendronate, brand name Fosamax, risedronate, Actonel, or ibadronate, Boniva. So typically preferred Fosamax, also use Actonel. IV would be mostly zoledronic acid, so brand name reclassed. Hormonal therapy, we talked about it. So estrogen in the right patient, so early menopause, those would be the individuals who would be on estrogen therapies. Raloxifene, we talked about the calcitonin as well. So raloxifene is the selective estrogen modifier. I won't talk about most of the trials, but just to give, this is a very pivotal trial that the first drug approved for osteoporosis, alendronate. So if you look at these individuals, so the primary endpoint was fracture reduction at the hip, spine, and wrist. About 2,000 patients studied. Mean age was 71. This was the entry bone mineral density. And they had the vertebral fractures on X-ray at the time of entry. So at that time, it was administered daily. Duration was 3 years. So this was impressive. So there was about 51% risk reduction at the hip fracture, about 47% risk reduction at the new vertebral fracture, and multiple vertebral fractures, about 90% risk reduction. So this was a very impressive result. We see kind of similar data across the other bisphosphonate trials as well. So roughly, if you want to remember an easy number, roughly 50% risk reduction of fracture. So when we discuss with the patients, who are candidates, we say it's not going to eliminate the risk of fractures completely. It's close to a 50% risk reduction that you will get when we're discussing about the benefits and the side effects. So bisphosphonates, so initial treatment of osteoporosis in postmenopausal women prefer oral bisphosphonates at the initial therapy, not necessarily because it's a superior agent, but it does have good efficacy. Patients with severe osteoporosis were also involved in the trials of the bisphosphonates. Favorable cost, the cost plays a big factor here as well as in India. Here, and it's mostly the insurance coverages. So bisphosphonates are generic, so they're going to be covered much better with the insurance. And there is also long-term safety data available for the bisphosphonates. So that's another positive factor. So alendronate or izodronate would be the preferred agents. Now, who would be not good candidates for oral bisphosphonates? So any individuals who are having esophageal disorders, so achalasia, scleroderma, or esophageal strictures, varices, so not good candidates. Or those who have had GI intolerance to oral bisphosphonates in the past, history of bariatric surgeries, ruined Y gastric bypass, or inability to follow the dosing requirements. So these are the individuals who are at a higher risk of having GI side effects. So the dosing requirements is typically we tell them take it. So Sunday, if they prefer Sunday, take it early in the morning when you get up, take it with at least 8 ounces, or let's say 2 glasses of water. And then you sit upright for at least 30 minutes. So don't get supine in those 30 minutes. If a patient is not able to follow that for any particular reason, then it may not be a good option for the patient. So coming to denosumab. So denosumab is also classified as an anti-resorptive agent. So it's a first-in-class anti-rank ligand monoclonal antibody. So monoclonal antibody, so the side effect profile will be lower for specific antibodies. So it blocks the rank ligand. So basically it prevents the activation of osteoclasts. So the FREEDOM trial was the trial which got it approved. So double-blinded placebo-controlled trial. Very impressive results. A reduction in vertebral fracture risk by about 68%, hip fracture risk by 40%, non-vertebral fractures about 20% risk reduction. So the patients who cannot tolerate or are intolerant to oral IV bisphosphonates, so the choice of agent, as we discussed, depends upon. So what's the risk of fracture? So T-scores, history of prior fragility fractures, comorbidities. What is the efficacy of the agent? Adverse effect profiles and the patient preferences. So whether they would like to have something daily or once in 6 months. So we'll talk about that as well. So you can consider denosumab for patients who are at a high risk of fractures, osteoporosis by bone mineral density in absence of a fragility fracture, or T-scores greater than equal to minus 2.5 beta fragility fracture, single vertebral fracture. So a very important thing about denosumab is, so it is administered subcutaneously once in 6 months. So quite a convenience factor for the patient. They just have to, it's just like in a subcutaneous insulin. You have to take it subcutaneously. It's once in 6 months. But what is very important is, so lately there has been very robust and good data coming for increase in vertebral fracture risk and decline in the bone density if you abruptly stop denosumab without a follow-up. So it should not be stopped without subsequent anti-resorptive therapy. So if you plan to stop it, so after 6 months of the prior injection of denosumab, you should make plans for transition to either bisphosphonate, hormone therapy, or selective estrogen modifiers. So this is a discussion which we have with the patient even before starting, is that this medication cannot be abruptly stopped. If we are stopping it, either we're going to transition to something. If the patient is, you say that probably it's not going to be a good follow-up patient, or compliance is going to be an issue, then denosumab may not be a good option for this patient. It, probably will increase the vertebral fracture risk or decline in the bone density after they stop it abruptly. So follow-on treatment prevents the rebound in bone turnover, and as we discussed, so rapid bone loss increases risk of vertebral fracture that may occur after stopping denosumab. So this is, I just wanted to show you very impressive data for denosumab. It's a very good agent. So if you see in this graph, so this is, from the, it's basically was an extension study of the initial trial of denosumab. So what you see here is, so this is the placebo arm, and this is the arm where patients are put on denosumab. So this is percent change from baseline. This is the bone mineral density. So if you see this, if you follow, this was an extension study done for 10 years, patient on denosumab. You do not see a plateau achieved here still. So, which, is very impressive because you're still seeing a gain in the bone mineral density. And this does also translate into fracture risk reduction as well. So in the placebo arm, what they did is put these patients also on denosumab, and you see the nice improvement in the bone density. Now, this is the 10-year mark, so we have data from longer than this as well. I have some of my patients who are on it since the start of the study. So I have some of my patients who are on it for 14, 15 years without having any, unexpected side effects. So it's okay to do it long term, but the only important thing is not to stop it abruptly. So just a few pearls about what we talked with these medications so far. So treatment with pharmacological therapies would be beneficial for individuals who are at a high risk of fracture with T-scores of -2.5 or less, clinical osteoporosis, where you can use the FRAX to help with this assessment, or history of recent fragility fracture. So this recent fragility fracture is very important. It's like we call it the lowest hanging fruit. So person has already had an event. The body is telling you, the person is telling you, I'm at an extremely high risk. I'm going to have another event if you don't treat me, as much as 20% risk in the first year. So these individuals, for sure, we should be thinking about treating them. Oral bisphosphonates as an initial therapy, not as a rule, but mostly, for the reasons I mentioned, we'll choose that as a first agent. But you could also choose denosumab, IV bisphosphonates, not a problem. Patient preference would be important. So raloxifene or menopausal hormonal therapy are considered if the patient is intolerant to the above. So these are weaker agents, so typically second line. Alternatives, calcitonin, we talked about it. It's the efficacy is on the lower side. We use it if any of the others are not available, or if we want to use it for short term for pain control. And this is very important. So when you're using these treatment options, you do everything that we did for the conservative management, and on top of that, the treatment options. Now, monitoring therapy. So ISCD or most of the societies typically recommend follow-up with the bone mineral density. So what we want to do is we want to wait at least there is a change which is more than the least significant change. So typically 1 to 2 years. Typically we do it every 2 years. With longer interval once the therapeutic effect is achieved. In conditions associated with rapid bone loss, if they have ongoing glucocorticoid therapy or anything else which is kind of, we think is an ongoing risk factor, you can test more frequently if appropriate. Now about the drug holiday. So bisphosphonates typically, they stay in the bones longer than you use them. So there is a concept of drug holiday. So meaning that you're trying to still achieve the benefits, but minimize the risk of side effects. So the way these bisphosphonates have studied in the trial for alendronate, the way it was studied is use it for 5 years. At the end of 5 years, you make a decision about the drug holiday. So whether to continue it for 5 more years, that was the extension trial, or you give it a break and then keep assessing about the risk. So we do it according to how it was done in the trial. So 5 years, assess risk, continue for 5 years, or give a drug holiday for a short period of time. For reclassed, that's the IV bisphosphonate, the way it was studied is 3 years. At the end of 3 years, you reassess, continue for 3 more years, or give a drug holiday. So when you are giving the drug holiday, so you keep reassessing the fracture risk. Consider reinitiating the therapy if there is a significant decline in the bone density, or an interval, a clinical event happens, a fracture happens, or other factors that alter the clinical risk status. So you can reinitiate the therapy. Now, coming to the severe osteoporosis treatment. So we talked about mostly, anti-resorptive medications. And, concepts lately, or in the sense, the way we think about it is changing. So here, a lot of things are dictated by the insurance. But as Dr. Kakatkar rightly mentioned, so with the anabolics, the concept could be, why not, just try to maintain it with the anti-resorptive. So why not do some bone building, or why not do some anabolic therapies and then maintain it with anti-resorptive therapies? So, I mean, not a bad option, not a bad consideration. That's also a reasonable approach. given the other factors. So patient compliance, cost, and everything is okay. But in most instances, we are going to use anabolic therapies for severe osteoporosis. So those would be patients at a very high risk of fracture. We do consider treatment with anabolics. So T-score minus or equal to less than -3, or T-score with -2.5 who have had a fragility fracture. So these would be typically classified as patients with severe osteoporosis. Anabolics would be considered in these individuals, severe or multiple vertebral fractures as well. So what is very important is after the anabolic therapy, so of the 3 therapies, so for Forteo, the way it was studied in the trials, that's how we do it, is give it for 2 years continually. So it's a daily subcutaneous injection. So give it for 2 years. At the end of 2 years, the most important thing, which, unfortunately, we still see a lot of times it does happen here as well, is not following up with anti-resorptive medication. So if you do not do that, the gains that you have achieved with all the efforts that the patient has done for 2 years, they're going to go down. So the benefits do not sustain if you don't follow it up with an anti-resorptive therapy. So this is very important for any of these anabolics. So yeah, just coming back to the list. So the last 3 would be the anabolics. So teriparatide, abaloparatide, romosozumab. So they work with different mechanisms. So they're going to also increase the bone resorption, but the formation is much more than resorption. So the net effect is positive. So there is improved architecture, increased bone mineral density, improved bone geometry as well, and then hence the decreased fractures. So the recombinant teriparatide, so it's the 134 recombinant PTH. So first anabolic which was approved in 2002. So it's they're around for at least 20 years. It's a very potent anabolic which increases the bone density significantly, reduces vertebral fracture risk by 65%, non-vertebral fracture risk by 54%. 20 micrograms subcutaneously daily for 2 years. Now this is a second agent, so abaloparatide. So it was approved after teriparatide. So Timlos is the brand name. So it's not necessarily superior, but effects are very similar to teriparatide. So this is bone mineral density change. So as compared to placebo. So quite impressive, femur, neck, lumbar spine as well. So the effects are very similar. So the way it was studied in the trial is for 18 months. So that's how we do it typically. So use it for 18 months and then follow it up with an anti-resorptive. This is the fracture risk reduction as well with teriparatide, abaloparatide. So not necessarily superior, it's just a blown up graph, but showing that equally efficacious. So this is the latest one which is approved. It's romosozumab. The brand name is Evenity. So this is an anabolic. Now the one of the big advantages, it is not a daily injection. So it is a subcutaneous once a month done for 12 months. So that's how it was studied, and that's how we do it. It's a very impressive molecule. So it's again a monoclonal antibody. It's an anti-sclerostin antibody. So sclerostin is produced by osteocytes and it inhibits bone formation. So basically what it does is it's an anti-sclerostin. So it inhibits this process and hence the anabolic effect. It was approved in 2019, so just recently approved. But the data is very robust and very impressive. So what we see is, so this is one of the studies which they did as a comparative study as well. So they studied alendronate, the Fosamax, teriparatide, and the romosozumab. So if you see the change in the lumbar spine bone density, what is very impressive also is that the separation of the grafts happened quite early as well. So this is 0 to 3 months. So this is with the romosozumab. So statistically significant as compared to the others at all the time periods, total hip and the femur neck. So with the other anabolics, with the teriparatide, what we see is if you study the bone markers, there is increase in the bone formation as well as the bone resorption bone markers. So, but the formation is, much, or I would say that is superior to the resorption. So we see a net gain. With the romosozumab, we actually see both, reduction in the resorption as well as the formation, from increase in the formation. So a very impressive molecule. We are very impressed with the results that were seen in the trial and that we see clinically as well. So this is an important addition to the medication list that we have. So Yeah, I'll stop here. This was just a brief overview. And if anybody has any questions, I'll be happy to take it.
Open for discussion.
Thank you, Shrikant. Shrikant, so do you mean that we need not have to give the raloxifene or the HRT to the perimenopausal women if they can tolerate the bisphosphonates or the they can afford the denosumab? It is not mandatory that we should go for raloxifene for them.
Yeah, I mean, very good question. So it depends on what indication we are treating them for. So if somebody is, having significant postmenopausal symptoms or perimenopausal symptoms, so in that patient, opting for hormone therapy or estrogen therapy may not be a bad idea. So that, is going to help with the symptoms of postmenopause as well as give some additional bone protection. Now, if, say, for example, that individual is starting at a T-score of -3 or beyond, so then just the estrogen probably is not going to be helpful if you're thinking about the bone health. So we may have to do, apart from the estrogen, the other medications that we'll use for osteoporosis. For the SERMs, similar. So we usually do not use raloxifene as a first-line treatment, unless you're using raloxifene for other indication, and that by the way, it's also helping with the bone health. So we will typically use raloxifene as a second-line agent if for some reason they're not able to tolerate both bisphosphonates, denosumab, or we cannot do anabolics, or as a follow-up. So say, for example, if we do anabolics and as a follow-up, if we cannot do either bisphosphonates or denosumab, we can do raloxifene. Does that answer the question?
Yeah.
Yes.
Can I? Well, in between, as I said, there is this osteoporosis essential meeting which I attended in Bombay. There were a couple of studies presented where they combined the use of teriparatide along with bisphosphonates. And in majority of the studies, it was observed that the efficacy of teriparatide, if it was used with bisphosphonates, was not to the mark. So in that meeting, it was recommended that in case you want to use teriparatide, then you have to use it initially. And as we discussed, and I think both of us agreed on that point, that after you build up the bone mass, then you put them on bisphosphonates as a maintenance, so that because I have seen a couple of situations where these two drugs are used in combination. So I think that particular concept should be a little more clear to everyone, that it is better not to use them in combination and use it in sequence.
No, excellent point. So I was actually going to talk about that, but with the time. But very good point. So you brought up a very important consideration actually. So to rephrase or just to reiterate, so it's with the combination therapy. So there has been a lot of interest with, so conceptually you say, okay, so these are anti-resorptive medications, these are anabolics. So if we use them in combination, can we get an additive benefit? But that has not been seen in the trials. So combination therapies, either with anabolics, bisphosphonates, anabolics with Prolia, we don't do that for that reason. There is no additive benefit. Now, sequential therapies, what to use when? So as we appropriately mentioned, very rightly mentioned. So if you're using an anabolic before a bisphosphonate or a Prolia, the results are much better than using, say, for example, somebody is already on bisphosphonates. Sometimes you have no option. They are on bisphosphonates, they fail therapy. You have to go with, say, an anabolic at that time. So we still do see an improvement in the bone density, but it is not as robust as if you would have used it as a first agent and then used a bisphosphonate. Actually, what we see is the one sequential therapy we don't really like is using denosumab first and then doing an anabolic. So if you do that, the risk of fracture goes up quite significantly in the first few months or the first year that you're using that anabolic. So you have to be just a bit careful about that sequential therapy, denosumab and then anabolic. Sometimes we have to use it. I mean, if they're either fracturing on denosumab or not tolerating for some reasons. But that's a consideration. But a very good point. So in summary, essentially, no to combination therapies. Sequential therapies are fine, preferably anabolic first and then followed by bisphosphonate or denosumab.
Another point which I would like you to enlighten us is when we face problem of atypical fractures in the femur with prolonged use of bisphosphonates, what should be the way in which we should, because we have seen that the implants break once, twice, and then we are not able to get the union. So is there anything that you can suggest by which we can tackle over this very difficult situation of atypical fractures by prolonged use of bisphosphonates?
No, very good question. This is a very important consideration. So not only dealing with the atypical fractures, but when we are making a decision also to choose the therapy. So for example, a patient when is very young, so that's an important consideration when we are trying to choose bisphosphonates, because the duration of therapy is going to be much longer. So that can influence the agent that we choose, for that exact reason is the risk of these side effects, atypical fractures. So typically it's duration dependent. So we are mostly going to see 5+, 7+ years, typically 10+ years of bisphosphonate use. And atypical fractures, so when we are counseling the patient, we say, okay, once you're on this therapy, anytime you notice and groin pain, please call us. We are going to, just get an X-ray at least to see if that is not the case. In our experience, most of these atypical fractures, when caught early, we just have to stop the bisphosphonates, they heal, not a problem. Sometimes, late or non-healing, that certainly is a problem. And apart from, all the good orthopedic care that you do, there have been, there's been very small studies to see if anabolics can be helpful to patients in these conditions. So there is some, positive data regarding that. So in a case-by-case basis, we may use anabolics in these individuals to help them with the healing for the atypical fractures. But it's difficult. So typically, if they are not healing by conservative measures, it's a difficult fracture to deal with.
Well, the further derivatives, as you have mentioned, after teriparatide, do they have some additional benefit in these kind of situations? Because we have seen that is the atypical fractures, you do an intramedullary fixation, number of times the implants break because the fracture refuses to unite. Yeah. So,
good point. So with the newer agents, so the abaloparatide is very similar to teriparatide. It's a parathyroid hormone derivative.
Yeah.
So we wouldn't necessarily expect anything different from abaloparatide as compared to teriparatide. Now, romosozumab is a bit of a different, it's a very exciting molecule, actually. We are very, so it's a classic example of how a molecule is developed from natural mutations and it is proved to be clinically beneficial. So unfortunately, though, it's been newer, so this has not been enough data to suggest that it would be beneficial or superior to teriparatide in this particular patient population where they have atypical femur fractures. I mean, it certainly could be tried to see if it is any better than, because teriparatide itself there is limited data. We don't use it very frequently for the atypical fractures. But it's worth a thought. I mean, it could be tried.
Okay. Thank you. Thank you very much.
Thank you.
Thank you, sir. I think, Gadegone, sir, questions?
So I think, thank you very much, sir. Tamhane, sir, you have given so much knowledge to us that I had the combination with the Kakatkar, sir. I think we have given a 4 lecture yesterday, also 2 and 2 today. So most of the points are clear. And I think it is a wonderful session. So for thank giving, I hand over to Dr. Pramod.
Thank you, sir. I thank our President, Dr. Gadegone, sir, Secretary, Dr. Karne, sir, for giving me opportunity as a convener for this MOA week celebration. I thank our esteemed two speakers, Dr. Kakatkar, sir, Dr. Tamhane, sir, for giving nice informative talks. I also thank Dr. Birasis and Dr. Arjun, sir, who are moderator and coordinator for today's talk. I also thank Dr. Kiran Savji, sir, Dr. Abbas Jable, sir, Dr. Paliwal, sir, Dr. Nahata, sir, and Dr. Shigeda for attending today's session as a faculty. I thank And I think we conclude today's meeting. Thank you very much.
Thank you.
Has the recording stopped?
The recording stop, you can talk.
Yeah.
No,
The recording is stopped.
Recording is still going on.
Okay.
Who is there from OrthoTV? Please stop recording. Sumit, Rushi.
I think we all can leave the meeting.
Yes,
Very
you will
nice.
leave the meeting, please.
Bye, sir.
Okay. Bye. Bye.
Bye.
चांगलं
Thank
झालं,
you.
Pramod. It was a good
Yes.
meeting, and I think we could give some new points and add
Yes.
something.
Hi Vijay.
Hi Sunil, काय म्हणतोस?
सगळं मजेत.
Nice to see
Bye.
you.
Same here. ऐकायचंय.
Actually, for fitness and osteoporosis, we are given 2 days, yesterday and today. So today's talk were also informative. Thank you, sir. Thank you.
डॉक्टर काकटकर,
बोल.
नाही तू एकच प्रश्न आहे. टी स्कोअर आणि झेड स्कोअर जे आहे ना, टी स्कोअर इज अ कंपॅरिझन बिटवीन द सेम सेक्स यंग अडल्ट अँड झेड स्कोअर इज कंपॅरिझन बिटवीन सेम सेक्स सेम एज. असं आहे. यू सेड चाइल्ड म्हणून.
Oh, Z score, as per what the theory says, is used for pediatric age group for comparison.
असं आहे ना. मला असं वाटतं की इट इज सेम सेम
No,
एज.
no, it is not that. I am 100% sure that T score is for adults and Z score is for pediatric age group. I have gone in details and then only I have prepared the slides. Yeah.
Thank you, sir. Thank you.
Chalo. See you. Bye.
Thanks.